very different topic to what we've been talking about in the last year, I guess, something surgical. We are very privileged to have Professor Urlesberger, the head of department from the Medical University of Graz Neonatal Unit from Austria. As you can see, he's very tropical. He's getting ready to go into spring and then summer. Unlike us, it's pouring rain outside. So he will speak to us about what the European Consensus Group has come to about the management of a very, very difficult problem in our neonatal units, congenital diaphragmatic hernias. So we'll follow the usual pattern of our Zoom sessions. Berndt will have the floor for 45 minutes or so. Type your questions on the chat pane. And when there's time, please feel free to raise your hand, unmute yourself, and ask him questions at the end. He has given us permission to upload the talk, and the talk has also been translated into Mandarin by Dr. Fan Yang from Hebei Children's Hospital. So if you need the slides in Mandarin, just contact me. All right, so without further ado, one more thing, sorry, some housekeeping. Don't be insulted if we mute you. It's just to decrease the bandwidth, and please turn off your video, otherwise the slides don't come through so well. So you have about, almost 100 people online now, Berndt. So we might pass the floor over to you. Thank you so much.
Thanks, Julie. So good morning, good evening, good afternoon, wherever you are in the world. Thanks for the invitation to talk about CDH and to talk about the European Consensus Group. And I would like to start. Doesn't work, so let's have this. Oh, like that. Okay. With the European Consensus Group for the management of CDH, you see it's a group that have members all over Europe, and I would like to acknowledge especially two persons, Dick Tibble and Erwin Rice from the Erasmus Medical Center in Rotterdam, who are somehow two leading persons within this CDH Euro Consortium. You see here where I am from. I'm from Austria in the middle of Europe, from Graz. And we have a problem with CDH because it's not that often occurring within our NICU. So studies in CDH are very difficult to do. And this was the reason why the CDH Euro Consortium was founded. And I am talking on behalf of this consortium, and I will show you what was done. The last update was done 2015, so it's about 6 years ago. It was published in 2016.
Yep.
And it's more or less a guideline how you may follow. So it's a protocol for standardized postnatal treatment. And I have to emphasize that it is expert. Okay, there's a lot of messages coming. Okay, there is an expert opinion. So most of the recommendations are level D. So let's start, and I will just jump into the topic and start with the ventilatory support, or the initial approach of these infants. So the recommendations within this consensus would have been that after delivery, you should intubate routinely without bag and mask ventilation. And after that, you have the goal to achieve an acceptable preductal saturation target that is between 80 and 95%. And the ventilation in the delivery room should be done with a peak pressure as low as possible to not to injure the lung, preferable with 25 centimeters of water or below that. And there is a recommendation not to use surfactant routinely in either term or preterm infants with CDH. There is a recommendation to use pre-medication given before intubation, if possible, but you should avoid neuromuscular blocking agents. So how about the surfactant therapy? You can see here, it's quite an old study from 2004 that in green you see those infants that did not receive surfactant, and in dark gray those that receive surfactant. And you can see that those that didn't receive surfactant had less need for ECMO, had a higher number of survival, and had a lower incidence of chronic lung disease. So we still recommend not to use surfactant within the delivery room in these infants, but this is not all. You can see on the right side of the screen that more or less in all these parameters, like the need for vasopressors, the need for inhaled vasodilatators, the need for sedation, and so on, was always significantly less in the group without surfactant use. I told you that the recommendation is to intubate the infant immediately. There is an idea that some of them might be taken care for with spontaneous breathing. And there's a statement which one might be the ones that we would do with spontaneous breathing. So in CDH infants who are predicted to have a good lung development based on the prenatal assessments, what are the criteria? It should be a left-sided defect. The expected over observed lung to head ratio should be above 50%, and the liver should be down. And only in these infants, spontaneous breathing could be considered. This is what the recommendation says, but I have to point out that the benefit of such an approach has not yet been determined prospectively, so this has still to be more investigated. There is a study from last year. It's where it's a retrospective analysis of infants of a single center, and you see that there were 71 patients with CDH, and out of them 18 patients, which means 25% of these 71 patients presented with a mild CDH, so they were considered being appropriate for having spontaneous breathing after birth. And 15 patients received spontaneous, excuse me, received the spontaneous breathing approach, because in 3 patients this had not been planned in before. And out of these 15 patients, only in 6 this approach was successful. So in the end, 8% had a spontaneous breathing approach that was successful. If we look just of those that really were thought that could be appropriate, of these 15%, then one could say less than half of them really were taken care with spontaneous breathing. So it's a small group of patients, and one has to be very careful in picking them out, I would say. Last year, there was a publication on spontaneous breathing with a physiological approach. In this study, persons looked on the tidal volume of spontaneous breathing, and you see here in patients that died and those that survived that there is quite a huge difference. This is twice the volume in the survived one compared to those that died. And in the analysis of all the data, the summary was that the tile volume was correlated with the observed expected lung to head ratio, and therefore it's not an independent predictor of outcome. Nevertheless, it could be useful as a measure to confirm the antenatal prognosis of severe hypoplasia in the future. But this is a very new topic, and we will see how this will develop further on. Of course, the volume question and circulatory points are very important already during the initial stabilization. So the recommendation in regard to blood pressure is that the arterial blood pressure has to be maintained at the normal level for the gestation. In the case of hypotension and or poor tissue perfusion, you would give a volume 10 to 12 mils of sodium chloride would be the normal thing to use, should be administered 2 times. And in case of persistent hypotension after the administration of the volume, inotropic and vasopressor agents should be considered. And not to forget, an oral nasogastric tube with a continuous or intermittent suction should be placed. So now let's switch to the strategy of ventilatory support. Still, there's a recommendation to use conventional mechanical ventilation. It is considered as the optimal initial ventilation strategy. And you see here, this is the one with the best grade of recommendation. It's C. High frequency oscillatory ventilation can be used but would be recommended to use it only as rescue therapy if the conventional mechanical ventilation fails. One should adapt the ventilation settings to reach a pre-ductal saturation between 80 and 95% and a post-ductal saturation above 70%. And the target for your PaCO2s is somehow in a range with a mild hypercapnia. It should be between 50 and 70 mils of mercury. This is because to keep out pressure from the lung and to keep the lung uninjured. Pressure-controlled ventilation is recommended, and the initial settings are to use a peak inspiratory pressure up to 25 centimeters and a PEEP of 3 to 5 centimeters, and a ventilation rate of 40 to 60 per minute. And after the stabilization, it's recommended to take care of the FiO2 and to reduce it again if your saturation values is above 95%. The gentle ventilation, you see here the impact of the treatment on the outcome, and you see that the gentle ventilation in this review had a significant better outcome, overall survival compared to HFR. So this is the idea why we still stick to gentle ventilation as the initial recommended ventilation. And there's a further trial, the well-known Vici trial, where this was a randomized trial, prospective trial to compare HFO ventilation for versus conventional ventilation. The trial had to be stopped because of problems with the inclusion of infants, but in the end, about 170 infants could be included, as you can see here. And if you look at the survival curves, you see that there was not a significant difference, but the survival was better here for in the solid line, you see the HFO ventilation. But if one looks into detail, you can see that if you compare those with HFO versus conventional mechanical ventilation, you see that not only the length of ventilation was significantly shorter conventional mechanical ventilation, but there was less need, significantly less need for ECMO, which is really a huge difference. So only the half of the patients needed ECMO using conventional mechanical ventilation, and there was less need for use for inhaled nitric oxide. So this is the reason why we consider HFO as being a rescue therapy and not a primary approach in those infants. The next problem all of us have with is the management of the pulmonary hypertension. We would recommend that one should perform echocardiography within the first 24 hours after birth, not only to rule out structural cardiac anomalies, but also to have a look in regard to the amount of pulmonary hypertension. The blood pressure support should be given to maintain an arterial blood pressure levels at normal levels for gestational age. And then it is recommended to start nitric oxide administration in the inhaled form for at least 1 hour in the dose of 10 to 20 ppm right early on in the course, and it should be considered if there is evidence of extrapulmonary right to left shunting and the oxygenation index is above 20. Or the saturation difference is more than 10%, the difference between preductal and postductal saturation. So in my clinical experience, more or less all our infants end up having INO within the first 24 hours. In non-responders for the nitric oxide, it is recommended that the INO should be stopped. Responders were defined as follows: a decline of 10 to 20% in the pre to postductal saturation difference, or an increase of 10 to 20% of the PaO2, or an improvement in hemodynamic parameters, meaning a 10% increase in mean blood pressure, or a decrease in lactate levels. So there are quite many parameters to consider who is an INO responder, and it's not easy to stop it very early on. The next recommendation would be that one could consider or should consider to use intravenous sildenafil in those patients with severe pulmonary hypertension, and in case of a suprasystemic pulmonary artery pressure and right to left shunting through the foramen ovale, the intravenous prostaglandin E1 should be considered. So this means one should not forget probably to keep the duct open in those patients. We know that the persistence of the pulmonary hypertension is really has some predictive value. And I would like to show you this study from 2015, where 180 infants were included, but 140 met then the inclusion criteria. And the question was, when do the pulmonary hypertension resolve, and has this some predictive value? And it had predictive value. You can see that in those patients where the pH was unresolved, that there the death rate was significantly higher. You can see here 60% versus 19%, versus 2% in those where the pulmonary hypertension was resolved, or that was able to be resolved. So this is a huge difference. And the mean time until the resolution of pulmonary hypertension was 70 days. So one can say that, especially starting with the week 2 of in these patients, the persistence of pulmonary hypertension has a very predictive value. And you can see here that in week 2, week 3, week 4, all those patients with still had pulmonary hypertension had significantly worse outcome and higher death rates. So this is an important parameter to look at. I like this figure because it somehow summarizes our problem over the first days. So let us go through the figure here. That's what we talked about the last minute, pulmonary hypertension. Here on the black, you can see the birth, and you have some time before birth. So we have here the fetal part and here the neonatal part of the disease. And you see, as you all probably know, that the pulmonary hypertension, if one would call it like that, exists before. But the problem very often is that the left ventricular hypoplasia is present. It's not only a disease of the lung, it is a disease that really has consequences for the development of the heart as well. So you can see here the left ventricular hypoplasia. It's a very important part of this disease. And you can see here the problem that we would normally face within the first 3 to 4 days. Because of this left ventricular hypoplasia, there is an increase in pulmonary venous hypertension. And together with the pulmonary arterial hypertension, this is really the big problem in caring for these infants. And here in the red zone, you see the phase where volotrauma and oxygen toxicity starts. We will see that oxygen toxicity might start earlier, but let's keep it like that. And you can see on this slide what are the therapeutic approaches one could think about here to solve the pulmonary venous hypertension. Very often the use of malrenone is recommended to avoid the volotrauma. The gentle ventilation, we already talked about that, is recommended. Here we have the pulmonary vasodilator therapy in this area of the pulmonary arterial hypertension. And here again, we have the IV use of BGE1 to keep the duct open, just to have a valve for extremely pulmonary hypertension. So I think this figure really sums up all our problems and brings it nicely to the point what we have to deal with within the first week in these patients. If we fail, then we would need to use ECMO. What are the criteria for starting ECMO treatment? The criteria within the recommendations would be 6 points: the inability to maintain the preductal saturation above 85% or the postductal saturation above 70%, increased PCO2 levels, and then respiratory acidosis with a pH below 7.15. Despite optimization of ventilatory management, peak inspiratory pressure above 28 centimeters of water or a mean airway pressure above 17 centimeters is required to achieve a saturation above 85. An inadequate oxygen delivery with metabolic acidosis and by elevated lactate levels above 5 or equal 5 millimoles per liter and a pH below 7.15. And of course, systemic hypotension resistant to fluid and inotropic therapy, resulting in an urine output that is below 0.5 mils per kilogram and hour for the last 12 to 24 hours. And last but not least, an oxygenation index equals or above 40 presented for at least 3 hours. So there are a lot of criteria, and you see here it's a problem. It might be a problem in oxygenation, might be a problem more in ventilation or ventilatory approach with high PCO2 levels, and it might be a problem in cardiocirculatory approach. There's still a discussion about the value of ECMO in these patients. This is a systematic review of the evidence. It's quite old. It's now 15 years old, but I think it's still valid to some point. And you can see here that there are not many patients that were included in this systematic review. We have 40 patients here and 40 patients here. And in the upper part, you see the analysis of short-term mortality. And in those, for this parameter, there is a significant result. For this parameter, ECMO would be favored. But if we look at long-term mortality, which was defined mortality after discharge in this review analysis, there is not really a significant result anymore. So if you look at the odds ratios here, there is some advantage in using the ECMO, but for the long-term mortality, it might have less value compared to the short-term mortality. So there's still a discussion about the value of ECMO in those patients. The next question, which is very important, is the time point for the surgical repair of CDH. This is a difficult part because I think there are a lot of opinions, different opinions on this part. That's what the Euro Consortium recommendation stated. It should be performed after clinical stabilization, so it should not be performed within or very early in the course of the disease. And the clinical stabilization was defined as follows: and mean arterial blood pressure normal for gestation, preductal saturation levels of 85 to 95s, on an FiO2 below 50%, so or 0.5, lactate below 3 millimoles per liter, and a urine output more than 1 mils per kilogram and hour. So these are the recommended parameters to start the surgical repair. Very often this is within the first week of life, but very often in my clinical experience, it's not before the third day of life. No routine chest tube placement postoperatively is recommended, and one can perform the repair procedure while the patient is still on ECMO. So this was the part where I talked about the consensus guidelines, and now Julie asked me to cover some of the recent topics and whether there are some updates to these guidelines. There are no updates to the guidelines, but there are some topics that are really came up within the last years. I would like to cover very shortly 3 of them. I would like to tell you that 2, RCTs, I'm sorry, this is a typo. 2 RCTs are running at the moment within the CDH consortium group, which is the CORDINOS trial and the Berndt trial. And there was a publication putting emphasis on long-term follow-up programs. So let's start with this. First, I would like just to inform you about the CORDINOS trial in the sake of time. I will be very short. With this trial, it is a randomized multi-center controlled trial of comparing intravenous sildenafil versus inhaled nitric oxide for the treatment of the pulmonary hypertension in neonates with CDH. And the primary outcome is whether pH persists and is higher in the group where we started with sildenafil versus inhaled nitric oxide. This trial, this publication is the publication of the protocol. The trial is still going on at the moment. I think the trial is now in the third year running now. And the other trial is the Berndt trial, and Berndt stands for physiological based cord clamping for infants with congenital diaphragmatic hernia. This trial just started, and both trials are coordinated and have PIs from the Erasmus Medical Center in Rotterdam. And this one is, I consider this one very interesting. We are a member of this trial as well. The primary objective of this protocol is to evaluate whether physiological based cord clamping results in a reduced incidence of pulmonary hypertension. So it's always the question how to avoid pulmonary hypertension in infants with CDH. It's a multi-center, non-blinded, randomized controlled trial, and it's coordinated, as I told you already, by the Erasmus Sophia Children's Hospital in Rotterdam. The inclusion criteria only left-sided CDH included, and only isolated CDH is included, and the gestational age has to be above 35 weeks of gestation. What does it mean, physiological based cord clamping? Normally, this term describes a cord clamping at a time point when there is already complete aeration of the lung. So it's not done with a timestamp. So we don't wait 2 or 3 or 5 minutes with cord clamping. What you look for is complete aeration of the lung. And if you have this complete aeration of the lung, you would cut the cord. Of course, this is not easy to define. So it was defined in the Berndt trial protocol that the cord clamping is done when the heart rate is above 100, the preductal SpO2 is above 85, with an FiO2 below 0.5. So this is quite a task to wait for that. And there is a maximum cord clamping time. You have to clamp the cord after the maximum time of 10 minutes. So this is the approach in this trial. And the question arises, why physiological based cord clamping in CDH patients? So to explain this, I would ask you to have a short look in the pathophysiology of neonatal transition in CDH patients with me. And I would like to introduce some publications from the recent years. This one is from the group in Melbourne, and you can see here, this is a study with creation of diaphragmatic hernia in lambs. And you can see here that you see here the lung area. So compared to the length of the femur, and you see that in patients with, in red, you see the patients with diaphragmatic hernia, there is significantly less lung area. And this is the summary. Infants with CDH have small pulmonary vascular cross-sectional area and increased distal vessel muscularization. And these structural changes influence the cardiopulmonary physiology during the neonatal transition. Let's go a bit more deeper in these patients, or in these lambs. And you can see here the pulmonary blood flow on the y-axis and the ventilation time in minutes after birth. And again, in red, those with the diaphragmatic hernia. And you see that there is less pulmonary blood flow in those and a higher pulmonary vascular resistance. But as we already heard, the volume of the lung is smaller, and if one's really indexed it to the lung weight, you can see that there is no significant difference anymore. So the lung aeration stimulated the large increase in pulmonary blood flow. You can see it here. The blood flow really increased in both groups. And this was proportional to the lung size. You can see here, those with the smaller lung size had less blood flow. But if you indexed to the lung weight, the pulmonary blood flow was similar between the diaphragmatic hernia and the control lambs, indicating that the lower pulmonary blood flow and the higher pulmonary vascular resistance are mostly because of the smaller lungs. What we see in those patients, if we look at PCO2, that the PCO2 was higher in those lambs with diaphragmatic hernia. And now let's have a look at systematic oxygenation, systemic oxygenation. And you can see here that the SpO2 levels were lower in those with diaphragmatic hernia, of course, or that's what we would expect, as well as the AADO2. But if you look at the cerebral oxygenation, you can see that the carotid arterial blood flow was significantly higher in the patients with diaphragmatic hernia. And there was a significantly higher cerebral oxygen delivery in those lambs with congenital diaphragmatic hernia. So during hypoxemia, titrating the fraction of inspired oxygen based on the oxygen saturation may cause an overshoot in cerebral oxygen delivery because of this fact. Why is this overshoot in cerebral oxygen delivery? The explanation that is given by the authors is that there is a sudden increase in blood pressure due to the loss of the low pressure circuit of the placenta after the cord clamping. And let's have a closer look in this. There are two effects in early cord clamping. First is that you have an increase in systemic blood pressure because you lose the low pressure circuit of the placenta. So, and this increase in systemic blood pressure is followed by an increase in carotid blood flow and subsequently an increase in cerebral oxygen delivery. And you have a pressure surge in that situation. So if you clamp the placenta before the lung is open and you have a low pressure circuit, the low pressure circuit of the lung really is somehow replacing the low pressure circuit of the placenta, then you end up with a pressure surge. And this pressure surge induces pulmonary vasospasm. And this is the reason why there's an increase in pulmonary blood pressure immediately in that situation. And this might be a problem that we have longer time or a fixation of the pulmonary hypertension. So that's the physiology behind this. I think I just put in this slide to remind you that cerebral hyperoxia is potentially harming the brains of our infants. And now let's go on to the next study where now the lamps, with these lamps with congenital diaphragmatic hernia, this physiological cord clamping was performed. And you see here now those with physiological based cord clamping, you see the pulmonary blood flow compared to those that had immediate cord clamping was significantly higher, and consecutively the pulmonary vascular resistance was significantly lower. So and going on with the cerebral oxygenation, you see that the cerebral blood flow using physiological based cord clamping was lower compared to immediate cord clamping. And you see that the cerebral oxygen saturation was higher compared to those with immediate cord clamping. So both had a congenital diaphragmatic hernia, both groups, but there were some advantages if you do physiologically based cord clamping. So we still talking only about animal experiments, but in those animal experiments, the physiological based cord clamping resulted in an increased pulmonary blood flow, in a reduced pulmonary vascular resistance, in a reduced carotid blood flow and carotid artery pressure, and did not show excess in cerebral DO2, oxygen delivery to the brain, and resulted in a more stable course of heart rate. So this is the idea behind this approach. I would like to sum this up in a more clinical way. So here you have circulation, fetal circulation, including the placenta. And you can see here, if we start the ventilation while there is still an intact cord and the newborn is still connected to the placenta, then you may have consequences. You may have an optimal preload because there is still blood coming from the placenta, and the placenta derives about 50% of the preload of the heart. Plus, there is an increase in pulmonary venous return due to the aeration of the lungs. So you have really an optimal preload. And if you give time to the whole circuit. You have a low afterload because the placenta is still within the circuits. So this approach just generates time to increase the pulmonary blood flow and to reduce the pulmonary vascular resistance. And then you clamp the cord, and in a more ideal situation when there is already aeration of the lung and pulmonary perfusion has improved. This is the first study in humans. It was a feasibility study, and it just showed that this approach is clinically feasible. We are doing this approach using the Concord table in Graz. We've done now about, I think, 5 or 6 CDH patients with this approach, and I can tell you it's clinically feasible. Here you see the baby, and here you see it in the operating theater. So the last topic I would like to cover very shortly is that we still have a problem with long-term follow-up. I like this figure because it really reminds us that congenital diaphragmatic hernia is more or less a lifelong disease, because it starts prenatally, and in this slide it ends up with 16 years. And you see that the task we have as over the time, and here in this publication, which was done 3 years ago by the CDH Euro Consortium, you can see here black, no follow-up, and in gray, follow-up. So you see here that in those centers where there are high numbers of CDH patients, there are higher numbers of follow-up programs, and the recommended follow-up topics are chronic lung disease, feeding difficulties and growth problems, the neurologic morbidity. So these are topics that we have to look at more intensively in future. And this publication tried to define what one should concentrate on and what we should look for. So coming to my conclusion, I would just like to be very short on that. Local guideline strategy, the definition, I think, is very important. We have one topic that might be interesting for the future, which is the physiologically based cord clamping, which may be helpful in the initial transition support. And I think we should consider, or we should remember, that long-term follow-up programs are still needed in patients with CDH. Thank you for your attention, and now let's have a discussion.
Thank you so much, Berndt. That was amazing. So you have a lot of questions online, and I'll try to summarize them, but maybe I could ask David Tingay, if you're still online, David, to unmute yourself.
David.
Yeah, he is pretty well known in this field, and Shupada Rao from Perth to give us your insight. So Shupada from in this situation. Shupada, are you still online?
Yeah, I'm online.
Oh, sorry, I can't hear you very well, Shupada. Okay, and David, is David still online?
Yeah, I'm here.
Oh, cool.
Yeah.
We have put some answers on the chat pane, which I shall transcribe onto a document afterwards. But maybe you could provide us with your thoughts on the use of high-frequency jet ventilation as both a rescue and an initial treatment for diaphragmatic hernias? Who wants to go first?
Berndt should go first. He's giving the talk.
Hi, David. Thanks. Yeah, of course it is. I think it's a very promising approach, but within our group, it's not an approach that we have a lot of clinical experience with this. I still consider it in neonatology as not a routine approach at the moment, but might be wrong with that. Within our group, this was not a routine approach, and so we did not state on that. But it's 2015, 16. I think it's a very promising approach, which is coming from pediatric intensive care and now really reaching as well neonatology.
I can comment next. Firstly, Bert, that was excellent. Thank you. It's a great consensus of guidelines and a very nice summary. I really appreciate it. It's nice to actually see your face again. Look, I think the high frequency jet ventilation is a therapy that's very regionally based. It's not available in Europe. It's widely used in North America, and it's only available in 2 sites outside of North America, I think, which is Perth and Melbourne. It has, just like delayed cord airway pressures you get with high frequency. So as I said in the chat, we tend to use it as a rescue of rescue when high frequency is not working, and as an ECMO preventing agent when we have that ventilator-induced lung injury and moving into that sort of more chronic phase of pulmonary hypertension, because high-frequency jet ventilation gives you very long expiratory times. So it's very good for conditions where you have gas trapping, which you don't see in early CDH, but you sometimes do in those babies later. There you go. That's my summary.
Thanks very much, David.
Beautiful. Then you have some questions about pulmonary hypertension, of course.
Yeah,
from
of course,
Kurt
yes.
Wall. Yes, Kurt the Wall. Can you unmute yourself and talk about PGE1?
Well, now one of the questions is related to this. This is great, Berndt, and I really like the European and the Canadian guideline to give us some sort of more ideas of what's going on and how fleeting this disease is. It goes from one phase to the next phase to the next phase. And in the pulmonary hypertension phase, some people now using PGE1 to keep the duct open to release the pressure of the right ventricle. But I wonder, you know, it's the pressure difference which drives flow along the lungs. And I wonder, are we targeting a high flow along the lungs or a low flow along the lungs? I'm not quite sure what the target. What do you think?
So, from a clinical perspective, I always used the PGE1 with the idea that I have some sort of protection for and still increasing pressure for the right ventricle, because it's some sort of valve. But of course, one could consider the hemodynamic consequences of the use of BGE1. I really am used to use it regularly, and I do not see strong side effects, but I do not see strong effects either. It's just the fear, to be very honest. You don't see it, but one has, as a clinician, one has the fear that if the pulmonary hypertension goes on and goes on and goes on, and you really have this type of right to left shunting, then the right heart would not survive this situation for the next days. So I think it's a very pragmatic approach, and I think we do not know all the hemodynamic consequences at the moment, if you just look in the details.
Yeah, no, thanks for that. Look, I think it's important to have the same approach. You start it, you measure it, and you see what the effect is, either clinical and hemodynamically, and to see if you might have to change to something else. It's a very dynamic disease, this diaphragmatic.
Yeah. Yeah.
Thank you. You look like you're going for a surf. Right. You can join Berndt in his tropical shirt. You've got some questions about other medications such as bosentan and vasopressin. What are your thoughts on those?
I have no personal experience with vasopressin, and I think the data are small at the moment, but I would say it's a very interesting drug for the future, yes.
And bosentan, David has said that the trials excluded the CDH kids.
Yeah. So again, I would just draw back to a very pragmatic clinical approach. So if you really have a very sick CDH patient, you end up with bosentan as well. So we normally in our unit, we start with nitric oxide. Most probably we would combine a sildenafil, and in the next steps would be combining bosentan as well, because we would do everything to avoid ECMO.
Okay, I do apologize if we don't have time to get to your questions on the chat. Maybe Berndt can answer them online, but we do have a few minutes left. So there are quite a few questions on how to ventilate these children. There's one from Dr. Madhusudan, who's asked you, how low can you go on volume guarantee? Is there a magic number?
No, I don't think so that there is a magic number. So it's difficult to estimate what is the right volume for that lung. From a clinical perspective, we have an idea if we see the PCO2 values, whether we have to deal with a very small lung or with a larger lung in that special patient. And we usually don't look that much on the volume in those patients. We more concentrate on the pressure, and we stick to this protocol, not trying not to use more than 25 centimeters of pressure. And as Kurt said, it's a very dynamic disease, and you can see changes every day, and I don't have an idea. We've seen in the study where there was the measurement of tidal volume immediately after birth, that those that died had a tidal volume of 2.5 mils per kilogram, and those that survived had about 5 mils, so which is quite in a normal region. So I think if you go below 3, this is probably problematic, but I have no idea from a clinical point of sight.
And maybe we will take a last question from Professor Sam in Singapore. What are your thoughts on a CDH in a very preterm infant, or those below 1,000 grams? When would you consider the corrective surgery? Damn, if you
Very
do
difficult.
right.
I haven't seen one yet, to be honest.
Sam, have you seen many? Anyone in the room?
I think, Julie, I'll comment. You know,
Hi.
we do see cases once in 2 years. And in my experience, almost all the ELBW, you know, who had CDH died, except the current one, 650 gram. And this baby, we waited until the baby reached, you know, 1,200 grams or so. And then surgery was done. And the baby is still on the ventilator. Yeah. Now the problem is PDA with left to right shunt, you know, and going for PDA ligation. Yeah.
So
we've had a few. Oh, sorry, Berndt, you go.
No. David,
I was going to say,
please.
Michael Stewart's listening in, and he knows about virtually every CDH baby in Australia, I think. So he might be able to comment, but we've had a few preterm babies, and I think a bit like your comments you were saying earlier about your sort of clinical acumen being required for this condition. I think the
But if you have one, I would still think don't be hesitant in just waiting for surgical repair, because there's no need to rush, and extremely, or especially in the very preterm ones, I would be hesitant to do surgical repair very early in the disease.
Well, Melissa Lewick from Westmead says she's got a survivor at 29 weeks. So that's very good.
Yes.
Yes, okay. So maybe one last question, because I think it's very important, from Gayatri Jabe, who asked what the best position for nursing these babies would be. And Shupada has answered that prone might be better. What are your thoughts on that?
So normally we do it in a supine position. I have no experience with a prone position in CDH patients, but they're that sick that normally they stay in this supine position, I would say.
Okay. Okay, that's lovely. Okay, so we're out of time. This has been an excellent talk, Berndt. Thank you so much. You had more than 212 people online at one time. And we have some comments here about preemies that have survived at 27, 28 weeks. And certainly this is a hot topic. And, you know, you've cleared up a lot of things for me. Anyway, I gave you a shopping list of things to talk about. So thank you very much. And also for those in the audience, this talk has been translated to Mandarin. So if your Mandarin is better than your English, give me a yell and we will send the slides to you. So Berndt is very happy to share, and I will upload his talk when it's ready onto our website and to our chat pages. So finally, for next week, we have Kurt lined up to talk about the heart of the heart of the preterm infant and how we can make your heart for life. So same time next week on Thursday. Please feel free to share the links when it comes around sometime over the weekend. So thank you very much again, Berndt. It's been such a to have you talk on this, and stay safe.
Thanks for inviting me.
Take care. Take care, everyone. Bye-bye.